Hello everyone, this is Dr.Ruchika, Assistant Professor in Suresh Gan Vihar University in the Department of Physiotherapy. Now, today the topic will be the movement ischemic contracture. So, if we talk about the Volkmann ischemic contracture, so I will describe or the definition of the Volkmann ischemic contracture is that it is a deformity of the hand, finger, and wrist which occurs as a result of trauma such as fractures, crush injuries, burns, and arterial injuries. So, following this trauma, there is a deficit in the arteriovenous circulation in the forearm, which causes a decreased blood flow, and hypoxia can lead to a damage of the muscle, nerves, and vascular endothelium. This result in the shortening contracture of the muscle in the forearm. So this is the brief introduction, or you can say brief definition of the Volkmann's ischemic contracture. So now we will move forward to our PPT. So the same thing, the Volkmann's ischemic contracture is a condition which is characterized by the ischemic necrosis of the structures in the forearm, extending to the lower arm and hand, and subsequent crippling contractures associated with varying degrees of the neurological deficit. So this is the introduction. Yes, it is the history. We read about the history. It is first described by the Richard von Bachmann. That's why its name is the Volkmann in 1881. But his name was associated with contracture later in 1889 by Hildebrand to describe the end result of any untreated, inadequately treated compartment syndrome and use the term Volkmann's contracture. So now we will move forward up to the you can say causes. So if we talk about the causes, the prolonged external compression, tight cast or tight dressing. So if the patient suffers from fracture conditions or the plaster of Paris is there or some sprain is there, so that the patient is applying some tight cast or tight dressing. So it is the external compression by that leads to the contracture. Internal bleeding, congenital or acquired bleeding disorder, post-operative or fluid extravasation. Okay, so because of this internal bleeding, congenital or acquired bleeding disorder that can be occurs, burns, trauma, snake bites, increased capillary permeability. Regional anesthesia that can lead to the, especially the intravenous regional anesthesia bias block. So this is the causes of the Volkmann's ischemic contracture, and I will just few explain about that. You can go for that. The bones are important factor in the Volkmann's contracture. We can see that the humerus of the upper arm is often involved in Volkmann's contracture. So this is about Volkmann's ischemic contracture, a claw-like deformity of the hand, named after the German doctor Richard von Volkmann. So upper limb, you can go for that. The muscles which are involved in this, or the causes involved in this: tight bendings, animal bites, burns, intensive and excessive exercises. So it is clinically associated with the fracture, supracondylar fracture of the humerus, or humerus is ischemia of the forearm due to acute compartment syndrome. Compartment syndrome is a condition in which there is an increase in the intrafacial pressure of any closed compartment in the body. This may occur due to two basic reasons: a decrease in compartment size or an increase in the volume of the compartment. So, described as an intrinsic or extrinsic compartment syndrome. Some other causes are muscular hypertrophy, neoplasm, bleeding into a closed compartment, injury to a vessel, congenital or acquired disorder, injections in the forearm, surgery to the forearm. Volkmann's ischemic contracture is described as a sequel of acute arterial insufficiency of the limbs. Emboli lodging in the arterial vasculature can also result in the ischemia of the muscle, resulting in the limb contracture. or so this is the subgroup analysis later showed that the ipsilateral displays extensive types of supracondylar humeral fracture or displaced forearm fracture had a prevalence of 33% for Volkmann's syndrome. So these are the few causes of the Volkmann ischemic contracture, and these are the supracondylar fracture of the humerus, as you can see in the X-ray, crush injury, contusion of forearm. Uncommon causes is just like chronic infection, congenital, and idiopathic sometimes. Now pathogenesis. Now VIC is the end result of prolonged ischemia of muscles and nerves in an extremity. Primary target is the muscle. Secondary target is the nerve. First, it involves the muscle, then, it involves the nerve compression. Muscle undergoes necrosis, fibrosis, and contracture. Nerve injury causes further muscle dysfunction, sensory deficit, or chronic pain. So this is about the pathogenesis. Few important topic also in the pathophysiology. So Volkmann's contracture develops when there is a usual sustained ischemic damage to the muscles. Diminished blood flow to the forearm, causing ischemia, may be due to increased compartment pressure or acute arterial emboli. Intracompartmental pressure of greater than 30 mmHg significantly impair the arterial circulation and are indicative of compartment syndrome. Contractures eventually develop due to prolonged myonecrosis, which stimulates fibroblastic proliferation, shortening of the cicatrix, and myotenous adhesions, resulting in fibrotic pull on the wrist and fingers. So these are the, you can go for that. These are the involvement of the muscles. So which muscles? There is a contracture of the muscles also. Usually the flexors of the wrist, or the contracture occur in the extensor of the wrist also, but there is less common. So muscles that are typically involved, it means you can say the muscles which are involved in this VIC or Volkmann's contracture. So this is the muscles are superficial flexors are the muscles. These muscles are the pronator teres. In this median nerve innervation is there. In flexor carpi radial is again median nerve innervation. Flexor carpi ulnaris, which is applied by ulnar nerve. Flexor digitorum superficial is median nerve. Musculus palmaris longus, median nerve, and D flexors, which are flexors pollicis longus, median nerve. Pronator quadratus, supplied by median nerve. Flexor digitorum profundus, that is the median nerve. So the intracompartmental pressure occurs when there is a bulging caused by a trauma. There is not enough space for muscles, nerves, and blood vessels that lie within the fascia. This results in the vascular defects and defects of nerves. So possible causes can be animal bites, fracture of the forearm, bleeding disorder, burns, excessive exercises, injections of medications of the forearm. So these are the muscles which are involved. So it is related to our clinical relevant anatomy. And if we go about the more involvement in the this VIC, so Volkmann's contractures can be classified into three grades: mild, moderate, and severe. So in the mild, this is a localized type of contracture which only parts of the flexor digitorum profundus are affected, commonly present as a flexion of a different limited number of fingers, two or three, usually involving the middle and ring fingers. Sensory loss is minimal, if it all presents. So Rowland's arteriovenous gradient theory, it is development of ischemia, is explained by this theory. Local blood flow. So this is the arterial pressure and the venous pressure. Blood flow reduces when this PA decreases, arterial occlusion is there, thrombosis is there, injury is there, and PV increases when venous stasis occurs. R increases when compression bandage, increase interstitial. So these are the things which involve in this Rowland's arteriovenous gradient theory. And about the pathophysiology, how it occurs, external or internal constrictions is there. So what happens? It increases the arterial spasm or occlusion, causes muscle ischemia, capillary permeability, causes muscle ischemia, that increases the capillary permeability, and that increases the intramuscular edema, and that leads to increase in the intramuscular pressure, further arterial compromise, muscle necrosis and replaced by collagen, and leads to contracture. So now by the action of microblast, contracture of the microblast shrinks necrosed tissues, followed by collagen deposition and cross-linking. It should be maintained. So these are the factors, or you can say these are the things which is involved in pathophysiology. So I'm talking about the grading system also. So in the mild, it is a localized type of contracture in which only parts of the flexor digitorum profundus are affected, or commonly present as flexion of the limited number of fingers, 2 or 3. In moderate, this is the classic type of contracture in which the flexor digitorum profundus and flexor pollicis longus are primarily involved. Superficial muscles such as FDS, FCB, flexor digitorum superficialis, flexor carpi annualis, and flexor carpi radialis may also be affected. Fibrosis of the mentioned muscle leads to a typical claw hand picture, which presents as flexion of all 5 digits as well as the wrist. Sensory impairment in regions of the median and ulnar nerve is also common. So this is the moderate stage. Severe, this type of contracture develop in extreme cases and present as the involvement of both flexors and extensor. This result in severely distorted contracture with pronounced sensory deficit. Long-standing moderate Volkmann contracture have the potential of eventually developing into severe Volkmann's contracture. So this is about the 3 types of the Volkmann's contracture. Sudden ellipsoid infarct concerned. So these are the involvement of the muscles. These brachialis muscles, brachioradialis muscles, radial artery radial artery is not involved, but you can say radial artery is supplying all these muscles. Coronary arteries, flexor pollicis longus, brachial artery and medianum, flexor carpi radialis muscles, flexor carpi ulnaris muscle, and this flexor digitorum superficialis and palmaris longus. So if we talk about this above a diagram, so he described the axial oxygenation around anterior interosseous artery with center just above the mid forearm. So he described the axial oxygenation and around anterior interosseous artery with center just above the mid forearm. Middle third of muscle gets most involved in an ellipse with long axis along this region. Okay. Center of the muscle was most ischemic, and the region was close to the interosseous membrane. Deeper aspect of forearm, while the peripheral parts escaped moderate reduction in the mainline blood flow due to collateral circulation. So this is about the structures closest to interosseous membrane are affected centrally. Most affected structures are FTP and FPL on either side of the vessel and the median nerve. So these are affected in the VIC in the contracture. The following 3 grades: mild, moderate, and severe. In the mild grade involving the flexor digitorum profundus or 2-3 muscles. Moderate involving injury to the FTP, FDS, FPL, FCP, and FCP. Flexor carpi radialis and flexor carpi ulnaris. In severe, involving both the flexors and extensors. So you can see about this, the grading system, and about the mild, we will go for that mild, moderate, and severe conditions of the, you can see, inner microscopic view of the compartment. So that can lead to the this type of the deformity. So now if I talk about Walkman systemic contractures in details, or you can say if we go for that other characteristics of clinical presentation, in which you can even that you can see in the diagram. So this is about the clinical presentation of Walkman's contractures. Include, it refers to 5 P's: pain, pallor, pulselessness, paresthesia, and paralysis. So pain, we all know about pain. Pallor, it is a yellowish presence, yellowish significance, or you can say yellowish presentation of the skin. Pulselessness, reduction in the pulse. Paresthesia, the numbness is there, and paralysis. So pain is the earliest sign. Special findings, we can go for the bleach view at the level of the skin, that is the pallor. The wrist is in the palmar fraction, you can see in the diagram. Clawed fingers, yes, you can go for that in the diagram also, that the fingers are in the clawed position. Pain occurs with passive stretching of the flexors. Palpation of the affected region creates persistent pain. So the palpation of the affected region, when we palpate the affected region, it creates persistent pain. It is possible that pulsation cannot be felt in the swollen arm, mainly in the distal part, that is the pulselessness. There are also neurological limitations noticeable from the muscle that pinch the neural pathway. There is decreased sensation, and there is an observable motor deficit. So in we have the differential diagnosis also. So in differential diagnosis, only one thing is that is the pseudo Walkman's contracture. Pseudo means false, and it has the symptoms, but it doesn't include the compression. Or you can say we the 5 P sign and symptoms. Or you 5 P, in the 5 P's we got 3 P's, that is the pain, pallor, and paralysis. So but we cannot decide, or we cannot diagnose it the Walkman's contracture, but we can go from that the pseudo Walkman's contracture. In examination for a Volkmann's contracture, the findings are specifics. The main physical picture that sees the neurological deficit that occur in the nerves that pass in the affected region. The flexion of the wrist is a result of contraction and the loss of innervation. The deformity seen in this condition can be divided into different levels of severity: the mild, moderate, and severe. Diagnostic procedures, what diagnostic processes we will follow: pressure monitoring. Intracompartmental pressure can be measured by several means, including, because as such it is of the compartment disease, so the compartment intercompartmental pressure is increased. So how we will measure that? That is the Wick catheter by the simple needle manometry. Infusion techniques, we can go for that: pressure transducers, side ported needles also. Critical pressures for diagnostic compartment syndrome is unclear. Different authors consider surgical interventions if absolute ICP greater than 30 mmHg. Difference between diastolic pressure and ICP greater than 30 mmHg. Difference between mean arterial pressure and ICP greater than 40 mmHg. Now, what are the outcome measures, or we can go for that? What is the functional outcome measures of this? So, functional outcome measures: active range of motion of the elbow and the wrist, active and passive range of motion of the digits, shoulder and elbow strengthened using sphygmomanometer, hand strength measure using a dynamometer, pad to pad pinch, key grip and tripod grip strength measured using a Preston pinch gauge, sensation measuring using one Frey test, moving 2 point discrimination test, functional head sensation, Moberg pickup test, fine motor functions, Macaron assessment of neuromuscular development, that is MAND, and activities of daily living, Jepson hand function test. So this is about the different diagnostic procedures, or we will go for the subtest. Medical management. Prevention is the best management in this condition. However, there are times the surgical interventions will be indicated. The majority of Volkmann institutions contractures are caused by Volkmann supracondylar condylar fracture, and it is essential that all steps are taken to improve the healing of the fracture. When there is intracompartmental pressure more than 30 mmHg, it is an urgent fasciotomy is recommended to avoid further complications. Raised ICP threatens the viability of the limb and compartment syndrome, represent a true medical emergency. Thus, the need for decompression by removal of all dressing down to the skin, followed by fasciotomy, surgical opening of the fascia around the muscle to make more place for the structures inside. This is done to prevent the onset of the Volkmann's contracture. In moderate Volkmann contracture, tendon slide and neurosurgery should be performed. Median and along with the nerve and extensive transfer procedures. Finally, in severe cases of VIC, debridement of injured muscle may be performed with release of scar tissue and salvaging procedures. Range of motion and function after injury are improved by physical and occupational therapy. So this is about the medical management. Now we go for the physiotherapy management. Physiotherapy management after the surgery. It is important to ensure that the mobility is recovered by passive stretching techniques. These are the techniques which is followed to improve the muscle stretch, the muscle ability, flexibility, range of motion exercise to enhance the soft tissue elasticity. Another part of the therapy program involves activating and strengthening the weak agonist to ensure equilibrium in agonist and antagonist pull during joint movement. Progressive splinting, passive stretching, and tendon gliding as well as massage can be used in the mild to moderate cases of Volkmann's contracture. So, by the use of electromyographic devices, the patient can train its affected muscles with cooperativity. The patient is more alert, there is more interactions between the patient and the therapist. So, this is about the physiotherapy management of the Volkmann's contracture. So, if we talk about the differential diagnosis, one more differential diagnosis is the Dupuytren contracture. The Dupuytren contracture is the Dupuytren contracture, and one I told you about the pseudo Volkmann's contracture. So pseudo Volkmann contracture is defined as the inability to fully extend fingers. The fingers should not be fully extended because of mechanical entrapment in patients with the forearm fractures. Now, signs and symptoms of ischemia are absent in pseudo Volkmann contracture. There is relatively rare condition that may be seen in the pediatric age group due to that tethering of flexor digitorum profundus to a fractured ulna. Dupuytren contracture is a progressive condition characterized by permanent flexion of one or more fingers. The exact etiology is not fully known. Risk factors including chronic liver disease, alcoholism, smoking, and prior trauma. Dupuytren contractures begin as thickening nodules in the palm, later progressing to restrictions of finger motion. Volkmann's contracture has the ischemic fibrosis of anterior forearm muscles. So, for the purpose of the writing, we will say it limited to the presentation in the hand. Now, what are the prognosis of this VIC? The outcome of fasciotomy for acute compartment syndrome leading to Volkmann contracture depends upon the duration and intensity of the compartment syndrome. Prompt fasciotomy, that is within 4 hours, leading to minimal sequel. Prognosis of developed Volkmann's contracture varies greatly from case to case. It is, however, observed that nearly all patients suffering from contracture during childhood end up with a relatively short limb. Functioning free muscle transfer result in substantial involvement in hand function. In contrast, tendon lengthening causes recurrence of contracture in many cases. Generally speaking, tenolysis, neurolysis, tendon transfer procedure, and the removal of necrotic muscle produce good hand function in those who have sufficient muscle remaining. Complications. So there are few complications of the treatment of contracture. Volkmann contracture vary from procedure to procedure. Common complications of the fasciotomy would include altered sensation, dry skin, and scaly skin, pruritus, and discolored wounds. The unsightly appearance of the wound is also a cause of significant distress to the patient, with 23 of the patient altering their behavior to hide their scars. So now, over tensioning or under tensioning is also a potential complication for tendon transfer surgery. This may result even the most skilled hands as the knot used may loosen or slip. Hematoma formation and wound dehiscence may be cause for post-operative worry when flexor origin slide surgery is performed. Functional free muscle transfer surgery is also associated with complications. Flap loss, infection, scarring, and tendon adhesion formation being the most commonly occurring. Post-operative and rehabilitation care. So incision for acute compartment syndrome are all left open. Negative pressure wound dressing may be applied if the major arteries or nerves are underexposed. Dressing should be expectedly changed every 24 to 48 hours to prevent wound infection. Delayed primary wound closure can be used 7 to 10 days after the incision so that the swelling sufficiently subsides. Precise rehabilitation for Volkmann ischemic contractures varies from surgery to surgery. Immobilization in a cast or immobilization in a cast, or you can say, so this the dressing should be aspectically changed every 24 to 40 hours to prevent wound infection. Delayed primary wound closure can be used to 7 to 10 days after the incision so that the swelling sufficiently subsides. Precise rehabilitation for Walkman's ischemic contractions varies from to surgery. Immobilization in a cast or splint is recommended for 2 to 4 weeks. Gradual use of the limb may be begun afterward with increasing the level of activity with time. So this is about the consultation. So what happened in the consultation? So patient with VIC need to be managed by professional team. Primary management is to be done by a hand surgeon, neurologist, orthopedic surgeon, vascular surgeon. All be consulted timely as well. Plastic surgeon can play an important role in reconstruction if needed. Physiotherapists are also extremely important in both the treatment and post-operative care of the patients with Volkmann contracture. If reperfusion injury is also suspected, medical specialists and nephrologists must be consulted to manage the systemic effect of muscle necrosis. Deterrence and patient education. Proper patient education has the potential of diagnosing and timely treating VIC and acute compartment syndrome. Its prequel. Patient should be clearly and simply explain the sign and symptom of acute compartment syndrome and if untreated, its long-term effects. They should be guided about the importance of early intervention and its potential benefits. Patients with displaced supracondylar fractures must be cautioned regarding the high incidence of Volkmann contracture and how they must not wait in the case of symptoms of compartment syndrome being appearing. Patient with cast, splint and bandages must also explain the possible complications that might develop due to tight application. Now, enhancing healthcare team outcomes. The main goal is to prevent the development of Volkmann's contracture by early detection of the compartment syndrome. An interprofessional team, including primary care, which provides surgeons, physicians, and nurses, is required for that. Volkmann contracture is a preventable disease, and also, and all patients who have the potential of developing this contracture must be educated and looked after. Physiotherapists are pivotal, very important in the treatment of mild contracture as well as the post-operative management of other patients. Regular interdisciplinary meetings will help establish goal of treatment in case of Falkman's contracture develops. So this we all study about the Walkman's contracture. So it is a Walkman's contracture. So few questions is there like this: What Walkman ischemic contracture is reversible? So it is a permanent flexion contracture of the hand and the wrist, resulting in a claw-like deformity of the hand and fingers. So now we have discussed the other things. So let me show you one video so that you can see about this most common etiologies. So you can see the video here. So you can see that the situation of the patient of the claw hand in this. So it is a result of the ischemic injury that causes muscle and nerve necrosis in the involved compartment. Without the result of the muscle compartment, the muscle will die and the nerve will be injured. The limb become deformed. As you can see, neglected compartment syndrome, crash syndrome, fractures associated with vascular injury, bleeding disorder is also here. Now, early diagnosis physiotomy is necessary to avoid the development of VIC. Treatment is difficult over here. So again, it is showing that the which more commonly muscles involve FTP, FPL, FDS, and pronator teres. So most commonly is FTP, digital profundus, and then pollicis longus. So you can see the wrist is the flexion, thumb is an adduction, elbow is in the flexion position, forearm pronation is there, metaphalangeal is in extension, IP is in the flexion. So severe palsy in the distribution of the median and ulnar nerves. Volkmann ischemic contracture classic. It is the clinical picture of the forearm. You can see the patient is of the burn case that leads to the VIC. So again, move forward to the PPT for the multiple choice questions. So we have studied about the VIC, Volkmann ischemic contracture, and now multiple choice questions is for the an evaluation that how much we have studied about the VIC or what we gain after the VIC. So all of the following are the complication of supracondylar fracture of humerus in children, except compartment syndrome, myositis ossificans, malunion or non-union. So here we're talking about the complication of supracondylar fracture of humerus in children. So these are the complications except non-union. So non-union is the you can say the bone are not getting uniformly adjoined or the correctly union. So that is the non-union. So correct answer is the non-union. All the complications are present. Compartment syndrome, myositis ossification, malunion is present, but non-union is not present in the supracondylar fracture complication of the in children of the humerus. Now, Volkmann's ischemia contracture is associated with intertrochanteric femoral fracture, supracondylar fracture of the humerus, posterior dislocation of the knee, traumatic shoulder separation. So the correct answer is over here is traumatic shoulder. Sorry, the correct answer over here is the supracondylar fracture of the humerus. So this is the correct answer about the Volkmann's ischemic contracture. Now, most common muscle which is involved in VIC, we have studied about this. So this is the flexor. First option is the flexor pollicis longus. Second is the flexor digitorum profundus. Third is the flexor indicis, and fourth is the abductor pollicis. Abductor pollicis. So the correct answer is the flexor digitorum profundus. Now, most common complications of the supracondylar fracture of the humerus. So, which is the most common complication? Brachial artery injury, cubitus varus, myositis ossification, or VIC. So, the correct answer is over here is cubitus varus. First, the cubitus varus is there. If any other changes are over there, then the VIC is considered. Normal bone remodeling in response to stress was described by Powell's, Konteski, Wolf, Hugo, and Thomas. So normal bone remodeling is response to stress was described by the Wolf. So this is the multiple choice questions for the VIC. Now, if we move forward or if we go for a little bit different multiple choice questions, so now, if a patient involved in a road traffic accident present with quadriparesis, sphincters disturbances, sensory loss up to the upper border of the sternum, and a respiratory rate of 35 per minute. So the likely level of lesion is C4 to C5, C1 to C2, T3 to T4, T1 to T2. So which which lesion, the lesion involves in the C4 to C5, as it already involved into the upper border of sternum, respiratory rate on this is C4 to C5 is the correct answer. So which isotype is used for treating the bone cancer? So this is uh, SR, GA or hydrogen 123 or TC. The correct answer is over here is SR, selenium. So epiphyseal dysgenesis is a feature of hyperparathyroidism, and hypothyroidism. So epiphyseal dysgenesis is a feature of the hypothyroidism. So this is the epiphyseal dysgenesis is a feature. So if we talk about the continuing the education activity of the Volkmann's ischemic contracture, so it is a claw-like deformity, or you can say conclusion of the Volkmann's ischemic contracture. Is a claw-like deformity of the hand, named after the 19th century. The name Volkmann ischemic contraction is self-explanatory. Ischemia refers to the possible etiology and contracture indicates shortening. The condition is a permanent flexion deformity at the wrist and fingers that result in a claw-like presentation of the hand. This presentation is due to permanent shortening of the flexor group of muscles in the forearm and thus may result in the pain on passive flexion of the wrist and fingers. Now, the activity describes the evaluation and management of Volkmann's contracture and its prequel acute compartment syndrome and reviews the role of interprofessional team in evaluating the treating patient with this condition. So the objectives which we cover in this topic are the identify the etiology of Volkmann contracture, review the evaluation of Volkmann contracture, explaining the management option available for Volkmann contracture, or the outline interprofessional team strategies for improving care and coordination and communication to improve the outcome of Volkmann contracture. So these are the this is the Volkmann ischemic contracture. So you, if you have anything else or if you have any doubt regarding this, you can go for the comments in the. You can go for the any doubt or in the comment box. So fingers. So what happens if the compartment syndrome get untreated? So if the compartment syndrome can develop when there is a bleeding or swelling within a compartment, this can cause pressure up inside the compartment, and it causes permanent damage if left untreated. So as the muscles and nerves won't get the nutrients and oxygen they needed. So this is how this happens when the compartment syndrome goes untreated. So, how long does it take for compartment syndrome to heal? So, if weight bearing exercises don't cause pain in the affected limb, then you may begin to incorporate high impact activity. Complete recovery from compartment syndrome typically takes 3 to 4 months. So, this is the you can say this is the if this is the time which takes compartment syndrome takes 3 to 4 months to recover from this. to healing of the compartment syndrome. Now, other other factors which are involved in this. So some other factors of the treatment is massage is good for compartment syndrome. So sports massage can reduce the tension in the muscles in the affected compartment. This in turn reduces the strain on the tenderness attached to the bone of the compartment, allowing it to heal. It also prevents the syndrome from reoccurring once you resume your sport. Stretching also helps in that. There is not the compression stockings, or you can say compression socks are not good for compartment syndrome. Is already compression is over there. So these are the few questions which can arise in the about the Walkman's contracture. So thank you so much for listening this topic on the Ganviha channel. This is Dr. Ruchika, assistant professor in Suresh Ganviha University Physiotherapy Department.